Hi everybody and welcome back to the channel. And this week's learning is basically asking a question: should primary care clinicians test perianal sensation in patients with Cauda Equina Syndrome? So the background to this is we know from the GIRFT that if a patient says, "My bum feels numb when I wipe," then it's numb when they wipe. And that is enough to start to trigger further investigations depending on how long things have been going on. However, recently I heard from some clinicians who are quite senior who said that they still do perianal sensation testing, and they raised three reasons or points to justify why. The first one was that the evidence for the whole of the neurological assessment is poor, but we still do that. The second is that it can be used for assessment of neurological deterioration. And the third is if there were two patients with CES symptoms with only one MRI slot, then that can be prioritized to the patient with altered anal sensation testing. So let's have a little look at the GIRFT. So I sit over here in the primary community care side. So as we know there, if a patient has either sudden onset of bilateral radicular pain or unilateral radicular pain that becomes bilateral, or CES symptoms of more than 14 days and unchanged, then they are referred urgently into the service and managed appropriately. However, if a patient reports they have CES symptoms and it's been less than 14 days or worsening, then obviously we're looking at urgent A&E, MRIs, and onward management. So let's look at the evidence that you can see here. So there's 5 studies, with the top one being a correlational thing using a Kendall Tau B. The others were using a mixture of sensitivity, specificity, odds ratio, likelihood ratios, positive and minus. So as we know, sensitivity is basically the percentage of patients that would have the condition if they tested positive. So if we look at randomly, the study by Dion, which is sensitivity 38, that means if we had 100 patients with CES, then the test would pick up 38 of them. That would be leaving 62 false negatives. A specificity is the likelihood that they don't have it. So if there's 100 patients without CES, it would test negative in 85 of the 100. So there would still be 15 false positives, where the likelihood ratios is measuring basically the odds of having the condition. And we look at values for the LR plus of 5 and above, preferably above 10, with a likelihood ratio minus of 0.1, 0.2, so basically closer to 0.1, the better. The odds ratios, although we can see 1.4, which is above 1, the confidence intervals are not good and they cross 1, which is the line of basically no significance. The LR plus and minus are essentially poor. They're nowhere near the 5 or preferably 10 that we look for. So the tests generally are not showing much for the use of these tests in primary care. So let's look at the conversation. So first point, all neuro tests are poor, but we still do them. Obviously, as I said, a false positive dermatomal test or a false positive SLR is not catastrophic, but missing CES or delaying imaging absolutely is. The perianal sensation testing, as we said, is just too poor when comparing to MRI. So the next point, we need a baseline to monitor deterioration. But if up to 50% of false negatives, what baseline are we measuring? So that for me is not an argument. And then finally, the objective loss helps us prioritize MRI slots. Again, if we can have up to 50% false negatives with a test, how can we use that to actually look at who's getting an MRI or not? But the last point, though, was when I said, if a patient reports a numb bum on wiping and your perianal sensation testing is normal, would you still request an MRI? The answer, yes, which is right. So my point is, what is the point of doing an anal sensation test on a patient that it does not change our management? The sensitivity, specificity, likelihood ratios, odds ratios are poor compared to MRI, and it just causes delay, and it's quite a embarrassing assessment for the patient. So the take-home message, what do I do in my clinic? Well, I follow GIRFT. If a patient says they have numbness in the anal area on wiping and it's less than 14 days or it's deteriorating, then they're off to A&E. If the symptoms are more than 14 days and stable, then they're seen urgently in clinic, safety netted and signposted, and referred for the appropriate investigations. It is already generally accepted that anal tone testing is a thing of the past, and in my opinion, anal sensation testing should join it. I hope you've enjoyed this quick presentation. If you have, please like, follow, share the page. Until next time.